All right, Billy. Well, we were just talking about nosebleeds. We're going to go completely to the other end of the spectrum. We're going to go down to the colon. We're going to talk about diverticulitis. This is basically an article by Young Faduk in New England Journal of Medicine, October of 2018. And this is just a big one of these clinical practice articles that kind of reviews a topic. And this one they chose was diverticulitis. It's interesting. We actually had a diverticulitis paper in the LLSA articles, probably 7 or 8 years ago. And this is now popping up again, which I think is kind of interesting.
Because it's increasing in frequency. I mean,
well, that's
we're
true.
seeing more of it. We're diagnosing more of it.
I wish they had gotten into more of the sort of what's a conundrum about it now, more, which they did in this article. I'm a little disappointed in this article, but we'll get into sort of why as we go through this. Because you're right, this problem is it's increasing, and we're seeing it in younger and younger people. This used to be a disease of older people only, and it just isn't anymore. I think our diet is just so terrible in the United States that we've really gotten a lot of diverticular disease in younger people. And we know that what this is, it's basically your mucosa and submucosa kind of pooching their way out through the layers of muscular sort of lining muscular wall of your colon. There are little points of weakness in between where it can, by either pressure inside the colon or whatever other reason, it pooches its way out. And where the those weak spots tend to be where the blood vessels go through the wall. And so the sigmoid colon, which is kind of the collecting structure anyway in your colon, is where this happens most commonly. So a diverticulum is just that little poochy out thing. Diverticulitis is where that little diverticulum gets inflamed and complications can occur. And this is anything from abscess to fistula, causing sort of scarring and strictures, perforation, and frank peritonitis. So it can cause a big, wide range of things. And it turns out that overall, this is the 8th most frequent outpatient GI diagnosis. I'm not sure what to do with that particular number, but just know it's
well,
not
just got to know 1 through 7, and then you know where 8 is.
Yeah. Exactly.
But anyway, it's common.
Yeah, it is. And Billy mentioned, so the prevalence is increasing. There's just no question about it. I love this number. It's kind of scary. 50% of people over the age of 60 have diverticular disease. 50%. And even under 40, 5% do. And I know that our patient population where I work, it's actually remarkably common in younger people. And it's something you have to kind of push onto the radar of medical students and residents early on in their training because they're taught it's a disease of older people. But it turns out not necessarily, and depending on your patient population, you can absolutely diagnose this in 20 and 30-year-olds. So keep it on your radar. And not only because we have more diverticular disease, rates of diverticulitis have also risen. So we're getting more hospital admissions, and there are risk factors for this. So smokers are at more risk for getting itis, not just osis, but itis. Non-steroidal use, people who are basically couch potatoes, people who don't get much physical activity. Obesity increases the risk, and certain dietary things like low in fiber. So if you're somebody who basically just doesn't ever eat any fiber, you're at risk for this. Refined carbs, which is like we're specialists in refined carb consumption in the United States, and red meat, all of those things are increased dietary risk factors. So you can see why, as a country, we're kind of a setup for developing diverticular disease. And we're not exactly sure why you get it, to be honest. Is it that you have increased intraluminal pressure? Do you have gut motility doesn't work quite right if you're not eating right or if you're not moving around? Is it bacterial overgrowth? Do you get tissue ischemia? And actually, to be frank, you probably do get bacterial overgrowth in the diverticulum itself. And when it stretches enough that it can become ischemic, those make sense. We just don't really know why you get them in the first place. But I think once you have them, we have some idea of why you actually get inflammatory changes as well. And they can perforate. And if they perforate freely into the peritoneum in a big way, not just a little micro perf, but a big way, the thing just pops, you can get diffuse peritonitis. Now, what can happen with that is if you have an adequate omentum, if you have plenty of mesentery and enough omentum, you can actually kind of wall it off and end up with a localized abscess or a phlegmon. If you don't have a lot of omentum, if you're particularly an older person, this can become diffusely peritoneal pretty quickly. Or you can even rupture into an adjacent structure. So one of my favorite sort of cases that I've kind of loved to teach about is a guy I saw who said he was peeing air. He would go to the bathroom and it's called machine gun. It's like you pee these little machine gun pellets of fluid, these drops with air in between. That's basically a fistula between the colon with this perforation into the bladder. It can also perforate into the small bowel. So this thing can perforate freely, or it can perforate into an adjacent structure. And the clinical manifestations of diverticular disease we all know, especially itis. So you get fever. usually left lower quadrant pain, because remember, it's usually the sigmoid. Your elevated white count can be not so elevated in the beginning, but the sicker you are, the more likely it is to be elevated. And there are some people who will have it in the right lower quadrant. Now, some people, and you've seen this on some of the CT scans you may have looked at, have this sigmoid that looks like the Hindenburg, this gigantic, redundant, floppy around sigmoid that can flop over to the right side and cause right lower quadrant pain, even though it's still in the sigmoid. Or Asian patients. Turns out Asian patients are more likely to get true, honest-to-God, right-sided colon diverticular disease. So Asian patients are more likely to have the right lower quadrant pain. So it's usually left, but remember, sometimes right lower quadrant can be there as well. And that would be something that would be kind of an interesting LLSA question if I were a question writer. And then the other symptoms can be anything from diarrhea or constipation. Your bowel habits themselves don't necessarily get changed with diverticular disease. And depending on whether you have a perforation and like an abscess or a phlegmon, there may be some pelvic pressure as well.
Diane, you did a great job of describing how that redundant or lengthy sigmoid sort of coils around behind the bladder, and if it perfs through, you get this air in your urine. But I have seen several cases over the last few years at Stony Brook where someone's being treated for recurrent UTIs, usually an adult woman, and what they have is not a UTI. What they have is sigmoid intermittent diverticular disease, where the sigmoid is resting against the bladder. So they get suprapubic pain, they get GU symptoms, they have white cells migrating into their bladder because of this irritation right on the other side, but they don't have bacteria in there. So
that's a great case. So that's a really good case.
Yeah, so it's another one of those mimics of the sort of, it all sounds like it's GU, but in fact it's diverticular disease.
Nice. Now, we know that if we see somebody like that, or somebody who has left lower quadrant pain and a fever and tenderness, etc., our diagnostic test of choice is CT scan. It just is. Multi-slice CT. They recommend IV and intraluminal contrast. I'm not sure, honestly, for the itis you need to have the intraluminal contrast. If you want to see the little contrast-filled little bubbles coming off the bowel, maybe. But overall, the CT scan is the test of choice, no question. Its sensitivity, specificity is really great, 98% and 99% respectively. And it's really recommended to get in all first episodes. And then they actually recommend it as well in recurrent episodes in this particular paper. And I'm not sure that is the routine practice. One of the things I'm going to, again, this is now editorializing, not the paper itself, but I think someone who's not particularly sick with I'm now a little tender in my left lower quadrant, I'm not febrile, my white count's not up, I'm doing otherwise okay, there's no peritoneal signs, I've had it before, my colonoscopy showed it. That's not necessarily somebody that I would image again.
Nope.
They're recommending basically imaging in this one. I'm not sure. The sicker they are, absolutely.
Well, I can tell you that the last, because I reviewed this with some of the Emma stuff, specifically the colorectal surgical societies say that in that type of patient that you just described, it's my diverticulitis again, doctor, that it's a clinical diagnosis and they need no imaging.
Right, and I think that's appropriate. So this paper doesn't say that, and I think for the exam part of this, when you take the LSA exam, they recommend it. In real life, please don't, unless they're sick.
And Di, I would also point out that the image you've shown has no intraluminal contrast, and I don't usually order it with intraluminal contrast.
Yeah, exactly. So there are two things here that I think differ from our usual practice, and I think our usual practice is correct. But this is what the paper says, so we have to kind of tell you what the paper says for testing purposes. Now, the findings that they'll see on that multi-slice CT, they'll see thickened colonic wall, some stranding, they may see abscess, they may see localized air bubbles, which is kind of cool when you look at the CT. It's kind of neat. And they may see free air and fluid. And the free air, interestingly, is kind of in funny places. It's not your usual big blob of it that's in the sort of non-dependent area. It's floating. This may be in little trapped places within the mesentery. So you have to be careful looking for air bubbles in places where they shouldn't be. And the severity of CT scans predict recurrence, but they don't necessarily predict how sick the person is right now. So for instance, free perforation, where it's not just a little microperf and I have a little localized irritation, maybe a little localized abscess, it's truly everywhere. That is a clinical diagnosis. So the CT scan may not, it's your diagnosis there. It's not the CT that makes that diagnosis. And that's something that's important to keep in mind, that you trump a CT scan as far as somebody who's peritoneal, they're peritoneal. And if there's any evidence that they've perfed, boom, you're done. You are finished with that one. Now, the complications they get, they can perforate. We've been talking about that here ad nauseum. They can get a stricture. We mentioned abscess and fistula formation. We've talked about these complications, and that they may present with the complication, or they may just present uncomplicated. I've got diverticulitis. I just had some local inflammation, nothing that's a complication with this. Now, what's interesting is the need for surgery, particularly right now surgery, isn't really determined by whether you're complicated or uncomplicated. That isn't a driver of what determines whether you need surgery or not. So in fact, some of these complications they'll address way down the line. It isn't something they would address urgently right now. Sometimes it's only antibiotics. Sometimes it's a percutaneous procedure that they do. So surgery itself is not determined based on uncomplicated or complicated. What may be determined, though, is this Hinchy classification. And there's a modified version of this, but this basically starts from little tiny abscesses at stage 1 all the way up to stage 4, where you have basically poop in your peritoneum. You basically have leaked all of this sort of fecal material into your peritoneum. The staging does increase your mortality and morbidity rate. It doesn't necessarily increase your likelihood of having a surgery, but it definitely increases your likelihood of getting sick and dying of the disease. So, what do you do? Somebody comes in with diverticulitis. What do you do with them? So your job is, do they need to have some sort of immediate intervention or immediate surgery? And your job, honestly, is, do I need to admit them or not? And do I need to call a surgeon or not? In the hospital, they may have to determine whether the surgery is needed later, or somebody else is going to determine if they need surgery down the line. I'm going home. Do I need electively anything done at all? And whether that is done really depends on how sick the person is. So emergent surgery, and this is what all of us on this sort of listening to this need to know. So we absolutely know that somebody's peritoneal or septic, that's usually free perforation. That's somebody who needs to go to the operating room. They usually wash them out, clean them out, antibiotics. Those people, depending how sick they are, may or may not get a CT scan. I'll tell you that most people do, unless they are crashing and burning, because CT can be done pretty quickly.
And they want the anatomic detail. They want to know where and what they're going for.
Where is it? What am I going to get? What am I going to see when I get in there? So CT scans, although if they're super unstable, usually it is done. And the surgery that they do, they may just do a laparoscope. They may just kind of take a peek and shriek, go in there with the little patrol cars and look around. If it's bad, they may open it and watch things out. And what they'll usually do, if it's perforated, is they'll take that perforated segment of usually sigmoid, whatever perforated segment it is. They'll take it out. They'll just cut this thing out, and they'll do an end colostomy. They'll basically take the end of that bit, the proximal end, and they'll stick it through the skin, and you'll get an end colostomy. It's a Hartmann procedure. It turns out that 30% are going to end up with a permanent colostomy, and that's a complicated reasoning to that. Sometimes people just never go back for their second procedure, but this is a big deal. So emergent surgery is a big deal. Urgent surgery, where I don't need to run right to the operating room. This is where a CT scan can help you. It'll identify some of those complications we talked about, or people they have had a percutaneous drainage from something like an abscess, but they're not getting better. That's somebody who might need urgent surgery. And I'll tell you, at this point in the article, if you're reading the article as well, there's a lot of detail about what kinds of surgeries and all of that. We are going to leap over that because none of us in this is a surgeon, so we're not going to talk about it. And we're going to kind of skip up to more sort of uncomplicated cases. So we'll skip the surgery part. Let's go to those uncomplicated people, because most of them are. 75% of diverticulitis cases are uncomplicated, and a lot of them can be managed as an outpatient. But who are those people? So they can't have a high fever. They can't be immunosuppressed, so no immunosuppression issues, and no real significant lab or radiographic abnormalities. So if you have already said they're clinically, when I examine them, not particularly concerning, there are no high fever, no immunosuppression, and their labs and CT scan don't look particularly scary, those are people I can manage as an outpatient. And the outpatient trials that have looked at this, they find that as far as antibiotics are concerned, oral and IV are the same, so it's fine to put somebody on oral antibiotics. And to take it even a step further, there are 2 trials that say, well, do you even need them at all? And there are 2 trials that compare antibiotics to no antibiotics, and they show no difference in outcomes. Now, I'll tell you the reality is, though, in the United States, we usually do use oral antibiotics at discharge. I think it's still a standard practice. I think it's pretty much still standard of care. That may change, but I think, and this article sort of gives homage to the fact that, yes, we still usually do this. Usually 7 to 10 day courses of either a sort of ciprofloxacin metronidazole combo, or just something like amoxicillin clavulanic twice a day, either a single agent, combo agent, or ciprometronidazole. And then they recommend clear liquids, tell people the pain improves. I'm not sure there's a lot of data to support that, but the antibiotics are something in the US is kind of a standard outpatient practice. Then you have to decide who needs to stay. If it basically it's anybody else. So if they don't fit that category of, no fever, they don't look that bad, their labs are pretty good, they're not immunocompromised. If they're anything else, they should stay. So all the things that they list on this particular slide or in the article are logical. So they're immunocompromised. They have a white count that's high. Their CT looks scary. Their pain isn't well controlled. They have other things illness-wise that are scary. They can't keep things down. They have a terrible home situation. All these things make sense on why you would keep somebody in the hospital. And what they do then is bowel rest, so you just don't really eat much, pain control, and antibiotics. Often given IV, and basically covering the things you'd expect, gram negatives and anaerobes. So, and there's a sort of some suggestions here like ceftriaxone plus metronidazole, or a beta-lactam, or a beta-lactam with a beta-lactamase inhibitor, meropenem. There's other things that they recommend. The key is IV antibiotics, admit to the hospital if they don't hit the discharge kind of group criteria. And what you expect when you admit them, or even outpatient actually, is that they should get better within 2 to 3 days. And as they get better, they can advance their diet. But again, diet, there's not a lot of great sort of data to say diet makes a difference. If they're not getting better though, or if they're worsening either at home or in the hospital, usually they get re-imaged. And if they need draining, then they get drained. If they're not getting better and they don't need draining, sometimes surgery is done in those cases. If they find an abscess, there's different site, and this is something you as the person in the emergency department, you get a CT scan, it shows an abscess, and the abscess is 4 centimeters. It's not at all uncommon when you make the call to the consultant that they'll say, oh, cool, there's an abscess, how big is it? Because if you're calling a surgeon, they're going to say, oh, hang on a second. If that's a 4 centimeter, get IR involved, get the hospitalist, involved, get some IV antibiotics on board. I'm not your man. I'm not your woman. I'm not the person here. The surgeon's not the person necessarily will manage that. So size does make a difference when it comes to abscess size. And then ultimately, when this whole episode is calmed down, this diverticulitis episode is calmed down, follow-up colonoscopy should be done if they haven't had one in the last 2 to 3 years. But they used to recommend it all the time because you might be missing a cancer. Well, it turns out you're not missing a cancer. Concurrent cancer with diverticulitis and a cancer is rare. That's going to be a true, but unrelated kind of phenomenon. So that just refer for their usual colonoscopy screening. Don't do a colonoscopy on purpose because you think you might be missing a cancer. And who's going to recur? So it turns out if you've had one episode of diverticulitis, you have a 10 to 35% of a chance of recurring. It's uncomplicated. If you've had 2 episodes of diverticulitis, you're at a higher risk, and the severity each time is about the same. So you don't increase your severity concern. So if you have it, you have a significant shot at having it again. Free perforation rates are more likely if in the first episode, and this makes some sense. So this idea that it's the first time I've ever known I have diverticular disease or diverticulitis, first episode I have. Free perforation is more common in that group, which makes sense. If I've had it once before, I may come in sooner, or I may get evaluated sooner. So my perforation rate is probably lower in that second time around person. So it makes sense that the first episode, that free perforation is more likely in the first episode than later. And
I think of it as sort of like pancreatitis. First episode's usually the worst.
Yeah, true. That's true. That's true too. And then as far as recurrence, high fiber diet maybe will increase the risk of recurrence, but I'll tell you, go ahead and have your sunflower seeds, go ahead and eat corn. That doesn't seem to make a difference as far as your recurrences are concerned. And then elective surgery, basically perforation is something where they may go in and do elective surgery later, but overall the elective surgery is done down the line, not our decision. Resection, if they get resected, basically resection works. They take the loop that has lots of diverticula in it, it's going to decrease your risk later. So recurrent now drops significantly. Need for additional surgery drops a lot. So, and quality of life is overall better in people who do get resected. And again, that's not our decision. That's a sort of what they do as an outpatient kind of decision. But know that surgery is not at all uncommon because people tend to do better. So the questions that they didn't really answer in this paper, and some of them aren't answerable, are do you need to use antibiotics at all, oral antibiotics, particularly in the outpatient group? And when should I do percutaneous drainage in this outpatient group? Can I send somebody home and have that done percutaneously? That we don't really know. And then in recurrence, what kind of role does medical management have? And there's some options out there like rifaximin or mesalamine. We don't know if there's a role for those. And these are questions of uncertainty, things we don't quite know yet. So to summarize diverticulitis, we know it presents usually as fever, left lower quadrant pain, and an elevated white count. CT scan, usually just IV in real practice. According to this paper, IV plus intraluminal contrast is the test of choice. The sicker they are, the more likely you should admit them. So fever, white count, immunocompromised, clearly acute abdomen. Emergent surgery if they have an acute abdomen or they're septic. In those cases, you're going to have IV antibiotics covering gram-negatives and anaerobes, and they may be able to sometimes drain those abscesses cutaneously. And that some patients absolutely can be managed as outpatients, and there's just criteria of who fits this. Basically, they're not concerning. Consider antibiotics, probably standard here in the United States right now, covering gram-negatives and anaerobes. So, Billy, you have any other thoughts on this particular paper?
Well, I'll just tell you what some of the emerging sort of themes at Stony Brook. So first off, they're definitely aware of the Hinchey classification, and they're really comfortable if you can sort of resuscitate them, get them comfortable with Hinchey 1 and even 2s going home.
Nice.
Our decision assist will no longer allow you to give them Cipro and Flagyl because of the Cipro black box. So they're all going out on Augmentin. I am specifically having surgeons ask for rifaximin now.
That's expensive.
Yeah, way expensive. But they'll ask and they'll tell me, they've had it before, and that's what I want. I do like them to have defined follow-up if they're going to go home, and certainly they get, return precautions. But I think for a lot of ER docs, you get told they have a 3.5 centimeter abscess. You're like, you start digging in your heels that they can't go home, and they'll tell you that the literature will tell you that some of these can go home, as long as you can get to the point where they're tolerating PO and things like that. It sounds to me, just as sort of my baseline instinct that would be crazy, but no, they're sending some of these home. So
well, it's interesting because back before we scanned everybody, I don't know, I've been practicing long enough that we didn't scan everybody initially. Yep. And then we used to call that painful diverticular disease. It had its own name. It was probably diverticulitis that was mild. And we didn't send those people home with antibiotics. We sent them home with stool softeners and pain control, and we didn't even send them home with antibiotics. So it's interesting to watch it kind of come full circle, but now with imaging to prove what we're doing.
But I also would say this, in the abstracts, we did a whole thing on diverticulitis and outpatient management, and as sort of an old, what we considered a serious disease, automatic admit. And increasingly, these are going home. They point out, in terms of the antibiotic, no antibiotic discussion, that there are probably a lot of people who have diverticular disease, who've had a grumbling abdomen, and said, I'm just going to back off and have some yogurt or whatever, and they toughed it out at home and never got antibiotics and did just fine. Mm-hmm. So there is a spectrum of this disease. Among those that come to the emergency room are probably the sicker ones, but there are probably lots of people who actually either never prevented for care or just took, did some, home pain control and, sort of backed off and rested their bowel and got better on their own without antibiotics. So I think the idea that you might choose to not treat them with antibiotics if they're at the mild end of the spectrum. You've done the imaging. I certainly want to have high confidence in the diagnosis. So for me, these are almost all CT-based decisions.
I agree.
But at that point, I think it's reasonable to entertain that. In terms of people going home with abscesses of 3.5 centimeters, I do now invoke shared decision-making on that. I say, the surgeon's not going to operate on you. He'll see you tomorrow. And they say, well, then why wouldn't I go home? And so I'll do shared decision-making on those nowadays, and the surgeons are comfortable with that if they're clear they're not going to operate tonight.
And I think it's appropriate. I think it's these days they don't need to be in the hospital. It's pretty good data that they're probably fine, and I think you're just closing the loop is important. Make sure they have follow-up, but yeah, I agree.